Welcome all of you to the 63rd live webinar on orthopedic principles. We are back with Dr. Ajith Appuhamy from Sri Lanka. Dr. Appuhamy has completed his MRCS, FRCS Trauma and Orthopedics from the United Kingdom. He has also done his FEBOT exams, part of the European Board. He is also a member of the AO Trauma in Sri Lanka and is actively involved in academics and other teaching programs in Sri Lanka. So today is my honor to introduce you to Dr. Ajith Appuhamy for this lecture on aseptic loosening and wear characteristics in joint replacement. Over to you, Dr. Appuhamy.
Thank you very much, Hitesh. Good evening, everybody. Today, I thought I will talk about wear and aseptic loosening, which is very, very important topic in FRCS Viva and MCQ paper, because it's quite common in the Viva exam, basic principles, even for adult trauma table. They commonly questions about implant loosening, and then it's going to wear and characteristic wear. So there is no escape in FRCS exam. So if you don't know wear, I think you better try the next time. Don't take me that I'm discouraging you. It is such important topic. So we'll start with what is wear. Wear, because you need to know the definitions of wear, because sometimes they might start your Viva table. Okay, tell me what is wear. So if you don't know the definition, so first impression is quite important to carry on the Viva table and to get more marks. So if you tell that definition, it should be very clear-cut and it should be very defined. So it's a progressive loss of bearing surface from the material as a result of chemical or mechanical action or due to both. I will not discuss what is chemical reaction related to wear here, because I will concentrate about mechanical action related to wear in this topic. But corrosive wear, it is a separate topic, and you need to know about that in detail, about galvanic, crevice, and pitting corrosions. But I will discuss that as a separate lecture. Here, I will emphasize about mechanical actions related to wear. There are 4 mechanical wears we discuss here: abrasive wear, adhesive wear, third body abrasive wear, and fatigue wear. So what is abrasive wear? Abrasive wear means when you look at the articular surface in macroscopically, it's quite smooth and uniformly. There are some irregularities, asperities. When the articular surface are in intimate contact, and when it starts sliding one over the other because of friction, these asperities can develop separate particles, that is called abrasive wear. So it is quite common when the articular surface, one material is hard, other material is soft, then softer material give more particles compared to the hard material. So this is quite common method of wear producing in our total knee replacement and the total hip replacement, that is abrasive wear. This diagram I have mentioned that polyethylene material above and metal down. You can see the articular surface. I have marked some asperities, and because of one articular surface slide over the one other, because of friction, they develop particles. When you go to adhesive wear, when the 2 articular surfaces oppose over the other under contact load, what happens? This articular surface, they have molecules, they transfer in from one surface to the other, and they form the transfer film, tiny transfer film. What happens if they develop the tiny transfer film, that all of a sudden this articular surface start moving already separated part and attached to the articular surface. So that is the way. Initially it's ultimate contact, then it's separate from the articular surface, and then act as a free particles and they become adhesive wear. This is the articular surface I have drawn. This is a tiny bit of grayish color I formed that transform this free particles here once it's separated from the articular surface. Third body wear, that means once it's separated from the articular surface and then it's accumulate and it has a huge number of particles and go and again entrapped between this articular surface, and they develop friction over this asperities and articular surface, they develop abrasive wear again. That is called third body wear. When you go to the fatigue wear, this is quite important. Actually, this is a separate topic, and this could be a separate viva question. Not fatigue wear, could be a fatigue fracture. Fatigue failure, it's a separate viva topic. I will not go into that detail about under this fatigue wear, but I will explain what it is. When the materials, they are subjected to dynamic and cyclical stressing over these asperities, what I described before, that irregularities over the surface. What happens then the cyclical loading comes, this asperities, this articular surface get failed at a stress level, it's considerably lower than their yielding stress, considerably lower than their yield strength of that particular material. So this happens, this is decreased by increase the conformity of the bearing surface. Now example, that conformity is more in total hip replacement compared to the total knee replacement. Bearing surfaces are flat in knee replacement, but bearing surfaces are curved and it's more conform. So it is fatigue wear is less and fatigue failure is less in total hip replacement. Another factor is the thickness of the bearing surface is also, by increasing the thickness, that reduces the concentration of the shear stresses near that articular surface. So that reduces the fatigue wear. So you need to know what is fatigue wear. That is has the same definition like fatigue failure due to cyclical loading. That articular surface, they produce wear particles, they fail at a stress level considerably lower than the yield strength of that particular material. This is what I wanted to explain. Mainly this problem I mentioned is the knee replacement is where less conformity. And this is the diagram I drew here to explain that is a total knee replacement has less conformity compared to total hip replacement. Then talk about this fatigue failure. Another very common associated description is the SN curve. In detail, it should discuss in the fatigue failure topic, but I can do that lecture later on. But here I will slightly mention about that. This is my y-axis, that is a stress amplitude, and this is my x-axis that shows the number of cycles. When you draw the SN curve, and this is the endurance level. Endurance level means that is the stress level that the specimen can withstand for cyclical loading indefinitely without exhibiting any failure. Usually that endurance level will come as 10 million cycles. What happens? Usually total knee replacement and even total hip replacement, commonly total knee replacements are high chance of fatigue failure because that polyethylene wear, they are operated always above the endurance limit. Always above the endurance limit due to various factors like patient factors, implant factors, surgical factors. Don't get confused because this is well explained as a separate topic in the fatigue failure of the implants. So I will just mention these things to emphasize this fatigue wear. You need to know few more things because your examiner, even though start with the wear topics, can deviate to fatigue wear and then fatigue failure. That's why I wanted to, as sake of completion, I I wanted to touch this area as well. Okay, now we'll shift to another area, that is wear processes. So this area would be a MCQ in your MCQ paper rather than in Viva table. So there are two main processes we need to know. One thing is galling, other thing is a fretting. Galling is it's a type of adhesive wear. What I described is ultimate contact and then friction, then addition between articular surface, and they are sliding one over the other, they develop adhesive wear. This is very common in the Morse tapers. What happened in the Morse tapers, you know, I have drawn here. This is the female part, that is the bow, and the male part is the trunnion. When it's fixing, when we are assembling through this, what you call, through this, because it's fixing through the truncated cone, that is called frustrum. So when you are fixing that, assembling, or sometimes there is some micro movement between two articular surface, they develop adhesive wear. That is called galling. When you go to the fretting means once it in most tapers, at the junctions of the most tapers, there are some micro motion between articular surface and they develop abrasion of the asperative. It's a kind of abrasion wear. What happens as a result of abrasion is it leads to loss of the passivative layer, because usually in the metal surface, metal that articular surface or waste surface, there are passivative membrane. So by removing of this passivative membrane, it leads to a contact with the joint surface fluid, joint fluid. That will increase the corrosive mechanism and create the oxidized layer over that. With that oxidized layer is much more harder than the non-oxidized layer. When it's rubbing the hard surface, they produce more abrasion. They produce more abrasive wears. So that is the fretting wear. That's more common at the junctions of the Morse taper I have marked here. If you know these facts, because these things will be more question in your MCQ paper, don't mix it up everything. So try to keep in shelf in what is this, and this is what like inside your brain, and most probably you have to use that knowledge in your MCQ paper. So once it separates this abrasion wear, then it will lead to the articular surface and they develop third body wear as a consequential event, and it can cause a false Brenner lead. That is a MCQ word, buzzword you need to know, but not for the Viva topic. I don't think in Vivas they will ask in that detail, but there is a possibility, but probably they will ask about these things in your MCQ paper. Okay, what are the sources? What were sources of the joint replacement surgery? Mainly primary articular surface, as everybody knows, it's coming from the articular surface. Then secondary articular surface. Then cement processes micromotion, and cement bone micromotion, it's commonly in the cement fixation. And bone processes micromotion in press fit fixation. I will not go into that detail. What is cement fixation, what is press fix, that's a different topic, but I will, because I need to cover up the more important facts on the wear, so I will run through these things. Okay, now we'll go to how to measure wears. There are two types of wear we need to know in your exam: volumetric wear and linear wear. Volumetric wear is a volume of material loss. It measures by cubic millimeters per year or per million cycles. Linear wear, we can measure by radiographically. We measure the penetrations of the one component into the other. We call it, once it's visualized in this X-ray, we call that protrusion. So if you want to measure this linear wear and progressions of the linear, it's very important you need to get the previous X-ray, immediate post-operative X-ray and in between X-rays. Then you can compare what is the progression rate and what extent it has, what is the linear rate, everything you can measure. This is a very important slide, will question in your MCQ paper. It's the law of wear. That means what are the factors affect for the wear rate, basically, volume of wear. First thing is a load. Load is, if more load, more wear, volume of wear is high. Other thing is a sliding distance. Sliding distance, when you go to this hip replacement, then their sliding distance mean is articular surface. Head is large, sliding distance is large. So volume of wear is high. Head is large, that means their radial clearance is high. What is radial clearance? It is the difference between the acetabular radius and the radial head radius. In that difference between that, we call radial clearance. So if radial clearance is more, that means large head, that their volume of wear is high. But hardness of the soft material, it is not proportionate. If hardness is more, the volume of wear is low. So we can reduce the volume of wear by increasing the hardness of the soft material. Considering these three factors, there is an equation, because these three factors, they commonly ask what are the factors affect for the volume of wear. You know it is volume, load, otherwise it's a sliding distance or articular surface or radial clearance, all are proportionately affect. When it's increased, volume of wear increases, and but only the hardness of wear increase, but volume of wear decreases. So the equation comes, it's V proportionate to Lx divided by H, and the wear is also proportionate to the surface roughness. They create a equation V equal KLx. K means wear factor. What is wear factor? It is a factor for a given combination of materials that incorporate that hardness of the soft material and material properties like stiffness and wear resistance and availability of the lubricants and the surface roughness. If you know the three main these factors, that is more than enough, because it will be questioned in your MCQ paper. Then we'll go to bearing couples. There are two main types of bearing couples we talk under materials: hard on soft and hard on hard. What are the hard on soft? Metal on polyethylene, ceramic on polyethylene. What is hard on hard? Metal on metal, ceramic on ceramic. In fact, in your exam, in your Viva exam, in your MCQ paper, you need to know each and every types bearing surfaces, their qualities, their properties, their mechanical properties. But in this topic, I will not go into that detail because that's a separate topic. That's a mechanical property. We can talk it later on as a separate topic. But I will mention little few informations comes under wear. When you talk about the hard on hard, their bearing coupling is quite liable to get more wear volume. There's a high chance. Within first year, there's a high chance of getting a volume debris wear, volume of wear. And next thing is, as I said before, large head, that means greater radial clearance, there's a high chance of getting volume of wear. But when you talk about the hard and soft, they are producing volume of wear is quite linear, nearly linear over the time, not like hard on hard. Then what else? When you talk about the ball and socket, as I said before, sliding distance is more when the head is large, and their radial clearance is more, then wear is more. But load is minimum because of articular surface is more, mean the load affect to the unit area is minimum. So that will other way around reduce the volume of wear. So while increasing surface area increase the volume wear, the by reducing the load per unit volume reduced due to increase of surface area, that reduce the volume of wear. If you know that fact to under wear topic, that's enough. So I will shift to the next slide. Okay, now I'm getting to a very important area, that's the modes of wear. There are 4 modes you need to know. Mode 1 is the generations of the wear due to motions of 2 primary articular surfaces, that means 2 bearing surfaces as intended by the designer. Example, in the total knee replacement, polyethylene and the metal, femoral metal part and the polyethylene spacer. Those are articular surfaces. Those are intended by designer to slide each other. So those are bearing, those are the primary wear. So it is a mode 1. Mode 2 means primary bear surface rubbing against the secondary in a manner not intended by the designer. It usually happens, now imagine, in the total hip replacement due to excessive wearing of the polyethylene liner by femoral metal head, that will go and touch the metal femoral back, acetabular back, that will produce wear, that is called type 2. That is called mode 2 wear. One primary bearing surface rub against the secondary. When you go to the mode 3, it's a 2 primary surface with interposed third body. Due to friction and abrasion, they produce wear. Mode 4 means 2 non-bearing surfaces rubbing together, they produce wear particles, that is called mode 4. Example, backside wear of the acetabular line, fretting and corrosions of the modular tapering connection, and fretting between metallic substance and the fixation screws. You need to know how to explain these 4 modes. This is the area I thought I need to explain this effective joint space, because sometimes your viva table, even though that examiner intended to ask about osteolysis, implant loosening, but he will not start your viva discussion as straightforward like what is osteolysis. There is a possibility he will ask what is effective joint space, and through that he will direct your viva discussions to osteolysis and then implant loosening. So it's important you need to know what is effective joint space. All periprosthetic region where the joint fluid can have access, can move, and then all wear debris also can gain access to that space, that is called effective joint space. Example, now imagine, look at this acetabular, uncemented acetabular cup, and there is a screw fixation. Now here there is a joint and joint fluid is here. Now there is a possibility joint fluid can transmit through this space and can go around these screws, can go up to here. Sometimes there are some unfilled holes, so joint fluid can have access here. Through that can go into this joint space and can traverse around these screws. What happens if joint fluid can traverse through that space means the usually wear particles also it contains in the joint fluid, and wear particle also get access to this space. That is called effective joint space. It is very important you know what it is, because it could be question in your MCQ, and the viva topic will start with this topic. So example, as I said before, around the screws or unfilled screws. In the femoral part, you know the stem, it has a porous area and a smooth area. After the porous area, smooth area can get the access circumferentially. They get the fluid can contact through the stem, around the stem. Okay, now we'll go into the osteolysis. What is osteolysis? You need to know what is the definition. It is a biological phenomenon that can result in the implant loosening. This is principally caused by the polyethylene wear particles. Not that metal and ceramic also affect for this osteolysis. Yes, but to a very lesser extent, lesser degree compared to polyethylene wear. This osteolysis is influenced by three main factors: size of the wear particles, number of wear particles, and morphology of the wear particles. You need to know those are MCQ points. Size, that is submicronal size between 0.5 to 1 micrometers is more active and there's more liable to get osteolysis rather than large particles. If it is more than 1 micrometer, even though they develop giant cell response, multinucleated giant cell reaction, but it is not produce any osteolysis. But small particles less than 0.5 micrometers, they are quite inactive and they develop very insignificant reaction, not a osteolysis. So this size of the particle 0.5 to 1 micrometer is the active size for developing osteolysis. That is the MCQ point. Then shape, when you talk about that irregular particles are more active than spherical particles, then the number is more than 10 billion particles per gram of tissues. There's a high possibility of developing osteolysis. Now we'll talk about what is the mechanism. Actually, this I discussed this area in my separate topic when I talked about bone metabolism and their homeostasis, and under that topic also I talk about this, but I will discuss this again because I need to include this part under where, because osteolysis is very important and I can't miss this part even though I discussed this before. So mechanism, what happened, the formation of peripheral, that what happened, I discussed that effective joint space. So what happened, that all wear particles traverse through this joint space, and then what happened, they create the periprosthetic interfacial membrane between the bone and the implant. Between the bone and the implant, due to traverse of this joint fluid, they form the interfacial membrane. This interfacial membrane composed primarily two types of cells: macrophages and fibroblasts. These macrophages are actively engulf this wear debris at the bone implant intersurface. Once it is engulfed, this macrophages activation happens. These activated macrophages, they produce and release many osteolytic cytokines such as interleukin-1, interleukin-6, human necrotic factor alpha, and platelet-derived growth factor. What happens, these cytokines, they activate osteoblasts around the bone and they upregulate the rank ligand receptors on the osteoblast surface. In the presence of colon stimulating factor, this rank ligand bind to the rank receptors on the macrophages. That is called rank ligand rank coupling mechanism. Once it binds in this rank receptors with the rank ligand on macrophages, what happens that induce osteoclastogenesis that forms mature osteoclast. Then start bone resorption around the prosthesis. That is called osteolysis. So what are the main regulators here? This could be MCQ, rank receptors, rank ligand, and osteoprotogerins. I will explain what is osteoprotogerin. This is the mechanism I explained. This is osteoblast, which contain rank ligand, and this is the macrophages, immature macrophages with rank receptors. Once this coupling of this rank ligand, rank macrophages that get activate these macrophages and become osteoclast, and they bind and start resorption. At this level, there is another element called osteoprotogerin. This element is more compatible with the rank ligand. So this is competitively bind with this rank ligand and inhibit the rank binding with rank ligand. So it's the amount of osteoprotogerin that affects for the bone hemostasis. So that is why rank ligand osteoprotogerin ratio is quite important for the bone microenvironment, because it affects for the bone density. It is MCQ. So once it bind to this, once it matured osteoclast, what happened? They bind to the Hawkins lacunae by integrin, and this ruffle border, they as a rough surface, they create a low pH by 3 ways: carbonic anhydrase, OTP dependent proton pump, and sodium hydrogen exchange. They start degradations of inorganic matrix, inorganic substances, and by lysosomal enzymes such as tartrate resistant acid phosphatase and cathepsin, they start hydrolysis of organic substances. This is a mechanism you need to know how about osteolysis. Then what is osteolysis? Then what are the factors affecting for this osteolysis? We discussed it's a biological process. So it is a multifactorial process. It's a biological plus it's a multifactorial process. There are 3 main factors we need to discuss when you discuss implant loosening. Now in the exam, sometimes they will ask, okay, implant loosening, they shows you the X-ray and came to a diagnosis, okay, this is loosening of the implant, aseptic loosening. Okay, tell me what are the factors for this loosening? That is where you need to talk about this area. That factors for osteolysis. There are 3 factors: surgical factors, patient factors, implant and material factors. Always try to divide your answer, then examine knows if you are starting like this, okay, this fellow is very organized. This answer is very organized. So what are the surgical factors? Multiple factors you can discuss about surgical approach, component positioning, whether it's restoration happen, the mechanical and the anatomical axis, rotational axis restoration, and initial stability, whether it's press fit technique or cement fixation, and soft tissue balancing, third body wear, surgeon's experience. It's very important. You need to discuss as the last point. And not only that especially when the cement fixation, here when you come to the cement fixation, surgical, so whether we are removing the adequate cancellous bone medially, because then only cement column, if you are not removing, what happened? The cement column does not rest on the dense bone, cortical bone. It is important adequate removal. And adequate quantity of cement is also very important to fill the canal adequately. And the cement lamination and voids, those are important. and failure to prevent cement motion while cement is hardening. That's a separate topic I can discuss, because in cement hardening, there are 5 stages. In the hardening stage, we have to keep static of the implant. If we move even for the micro motion, that will affect for the implant loosening. Another thing is implant positioning. We have to neutralize, and mildly valgus position we have to keep rather than medializing. So those are the surgical factors affect for implant loosening. When you go to the patient specific factors, activity level, the patients are very active, running, jumping, so high chance of implant failure. Because activity is low, sliding distance is more. Activity is more means sliding distance is more. And young age, very active, high implant failure. High weight, BMI, body weight, and gait mechanism, limb alignment, sometimes other comorbidities, sometimes cultural demands, people knee down as a cultural thing, kneeling, so high chance of failure. And whether it's the primary or revision, second revision, so those are the factors. Then go to the implant factors. We can, the implant design choice, whether it's a modular or whether it's a monoblock. If it's a modular, strain is high, there's a high chance of wear, producing wear. And the thickness of the polyethylene and the bare coupling and fixation and how constrained and implant impingement, those are all implant factors. And what type of material we are using, with the polyethylene is a high cross or conventional. So metallic alloy or ceramic, those are affect for the implant loosening. And bearing coupling, I discussed metal on polyethylene, whether it's a ceramic on polyethylene or metal on metal or ceramic on ceramic. And quality control, the type of sterilization process they have used, whether it's radiation or ethylene oxide, all affect for this loosening. So now we'll step into a new area, that is a zone of loosening. So it is very important, because in your exam you need to know these loosening zones, because evaluation of radiographic stability by using zonal analysis is important. We explain Gruen zone for the femur and the D. Charnley zones for acetabulum. Remember here you can see in the Gruen zone, usually in the AP view of the anteroposterior view, there are medial and lateral zones, starting with the superlateral number 1, then number 2, 3, and beyond the tip is 4, then it's go up to 7. This is the number system we commonly use. And at the same time, the lateral view, 8, 9, 10, 11, 12, 13, 14. If you go into the lateral view of the femur, we can divide into these zones. When you go to the acetabulum, there are 3 zones, 1, 2, 3. Important thing I need to mention here, usually in implant loosening, we can see a sclerotic line at the bony edge. We can see the radiolucent line. Above that radiolucent line, we can see the bony sclerotic line, thick whitish line. But if there is a age-related expansion of the femoral canal or thinning of the femoral cortex, this also appears as a radiolucent around the process. But in this situation, we cannot see that sclerotic line. So it is very important, you need to know how to differentiate. Sometimes they will ask that kind of a tricky questions wherever that sclerotic line is more dominant. And how do you say this is the loosening or could be the age-related bone expansion? So if you know if there's how to differentiate using this sclerotic line, I think that's the important fact. And next thing is this radiolucent line, especially in the acetabulum and this femoral, we can see some irregularities. Those are not very regular radiolucent spaces. Sometimes this is irregularities, depend on the cortical loss, bone loss. Okay, now using this, after this loosening zones, I will go into modes of cemented femoral stem loosening. This is 4 more. This is also very important because they will show you X-ray and ask what is this mode of femoral loosening method mode. There are 4 modes we discuss here. One thing is pistoning behavior. What is pistoning behavior? It is a sliding. It's a radial loose. This pistoning, there are 1A, 1B. 1A means there's a radiolucent line between the stem and the cement. Between the stem and the cement, and mainly at the mainly at the superolateral part of the stem. What happens, stem is migrating more distally and they produce very radiolucent zone at the distal part, and sometimes they will do a punch out fracture. They will do a punch out fracture at the tip, near the tip of the cement mantle. 1B means we can see the again sliding down, it's a distal migration, but we can see the radiolucent line around the cement mass, between the cement and the bone. There is a picture, yeah. You can see it is sliding down. Here you can see it is going down. It is a pistoning behavior. You can see the more loosening line at the superolateral region. Second mode is a medial mid-stem pivoting. Medial mid-stem pivot means due to the medial migration of the proximal part of the stem and lateral migration of the distal part of the stem. Why this medial migration happened? Due to inadequate support. Due to inadequate support from the supromedial part, that means less cement, and inadequate support from the inferolateral part of the cement, bone part. So high chance of getting fracture of the bone cement at the mid portion of the stem. So here proximal part is migrating medially and the distal part migration distally due to inadequate support from the supromedially and inferolaterally. Bone cement can fracture at the mid shaft area. So example, here you can see this proximal segment has shifted medially while this distal segment has shifted laterally. When you go to the third part, that's the calca pivot. Calca pivot is quite due to adequate fixation of proximally, and distally it is loose. So it is a toggling with medially and laterally. It creates a windscreen wiper type movement. Windscreen wiper type movement. Proximally it's well fixed, distally it is loose. So here you can see it. The last one is a cantilever failure, that is quite common in the fatigue failure. This is the picture. Usually in the Viva questions, if they want to questions about fatigue failure, they will give this X-ray and ask you to describe and what is this failure, what is the mode of failure. Then you have to tell it is a fatigue failure associated with cantilever bending. What happened here? This is proximally is not support properly, but distal is well secured and fixed. What happened is toggling proximally. Because of that is here this stem fracture at the mid of the shaft. So those are the modes you need to know about cement femoral stem loosening. This is the X-ray you need to know, and this is the area you need to know about fatigue failure and cantilever bending. This would be a viva question. But I will discuss that separately because it is another large area. Okay, now we'll go to how do we assess radiographically. Now we discuss loosening areas. Now we assess radiographically this loosening. This Harris criteria in 1982, Harris has done a study with autopsy biopsy. Autopsy study. So he has classified definitive loosening, probable loosening, and possible loosening. Definitive loosening is a subsidence of the component, fracture of the stem, cement mantle fracture, and radiolucent line between the stem and the cement mantle, which is not present in the immediate post-operative X-ray and which is present now. So that is we classified as a definitive loosening. So we have to think about revision if you find one of these things. But when you talk about probable loosening and the possible loosening, it's a probable mean radiolucent line at the bone and cement interface that is either continuous or more than 2 millimeter wide at some point. Possible mean radiolucent line at the cement and bone interface between 50 to 100% of the total bone and cement interface, not present on the, which is not present in the immediate post-operative X-ray. But there is some argument, and later on, the Harris has done another study in 1993, and he has proven and he declared that probable loosening and the possible loosening are no longer valid and useful, because he has proven this radiolucent line was more, in this probable and possible loosening, the whatever he described that radiolucent line, it came as secondary to adaptive remodeling rather than the disruptions of the bony continuity. So because of these things, so we don't concentrate much about possible and probable loosening. So we go for the definitive loosening. If we take, we'll consider, otherwise then we do the further studies to see, and we'll compare with the previous X-rays, and I will discuss what we are doing later on. So these are the features to consider loosening: step migration, subsidence, fractures, osteolysis more than 5 millimeter is the radiolucent line, so it is obvious, and sometimes it is increasing by 2 millimeter compared to previous X-ray. It is positive. Then radiolucent line mainly between the stem and the cement and the supremedial part of the stem more than 2 millimeter. Yes, we have to think of loosening. And radiolucent over the all groove zone. All groove zone between the stem and cement more than 1 millimeter. We have to think about that. And other thing is the inadequate cementation and cement thickness. That is for the femoral stem. Then acetabulum loosening, if it is more than 2 millimeter or which is progressive compared with the previous X-rays, we have to think about loosening. And cup migration, medial migration, that is called protrusion, and change of the inclination compared with the previous X-rays, the cup is more inclinated with the post immediate X-ray, so we have to think about loosening. And eccentric polyethylene wear, so always compared with the previous X-ray. Previously that compared to the cup, the head is at the middle, but now it has shifted more towards down or up, that is eccentric wear. Then cup fracture and the simple cement mantle fracture. So we consider it's the acetibular loosening. Those are the radiographical features you have to think, and you have to leave. If you find anything, you have to explain in the X-ray. These are the things. Okay, this is loosening. Okay, we'll go into another important area, that is grading system, which is recommended by Barak. That is called Barak cement grading system. He has graded A, B, C, D, 4 types. A is a medullary canal is completely filled with the cement. It is white out, no distinguishable border between the cement and bone. B is nearly filled. There is a slight radial loosen existing between the bone and cement interface. So AB we usually consider this a good grading, and it is stable, no loosening. If you find this complete whiteout around and there's a slight radial loosen, so we'll look for symptoms and the history examination findings. If it is not compatible with the findings, so we'll consider it is something artifact or something. So we'll not go into much detail. But C and D, there's a high chance of loosening if they show C and D features. C again divided into 1 and 2. One thing is the intersurface is more than 50, it is C1. That mental area is thickness is less than 1 millimeter, it is C2. So when you go to D, it's the radial looseness is more than 100 in the bone cement interface, and sometimes absent cement disturbs the tip of the femoral stem. And sometimes gross deficiencies around the stem and multiple large voids. So those are the C and D features for the cement grading, Barak grading system. So when you talk about the pros and cons of this Barak grading system, it is C and D, it has a greater rate of aseptic loosening. So we can get a good idea. But the thing is, it has a higher or inter-observer variability. In addition to that, influenced by the amount of cancellous removed during reaming and broaching. Now imagine if you remove the entire callus board, and we put the cement. Once we remove the entire callus, it shows as a whiteout, no radial loose. But the thing is, if there's no callus, no foothold for the cement, like that, there are drawbacks. But we'll stick on this and there are rules for cementing. They are telling to avoid loosening. At least they advise to put the 2 millimeter thickness, and 2/3 rule that states about 2/3 of the femoral canal should be filled with the femoral stem, while the rest 1/3 filled by cement. Later on, Mulroy. So if you go to the Viva discussion, if you go into some research article, so you can easily score from 7 to 8, high score. So it's a Mulroy report. They say that the cement mantle is less than thin, and defects of the cement mantle, there's a high chance of early loosening. Okay, now I explain you what is where, what is background, what is pathophysiology, all these things. Now we'll get into exam question and how Viva questions discuss about these things. Now, in exam, they will show you this kind of X-ray. Why I selected this both side bilateral prosthesis? Because always examiner try to confuse you. So you need to identify the exact pathological side that will give MOMA, that will guide you to the correct direction. Now, if the examiner says, okay, tell about this, something about this X-ray, and tell how to manage this patient, don't spend your time to explain the normal side. Just explain the pathological side compared with the normal side, because they are giving the both sides just to compare, and go back to the management as early as much as quickly. Now, looking at this X-ray, you can see compared to the left side, the right side, you can see the significant radiolucent line around. and can see that it is a distally migrated, no? Compared to this, it has distal, it is pistoning down. And you can see even the femoral part, femoral cup, it is kind of inclination, and can see the radiolucent and the Lee Charnley zone 1 and 2. We can see the radiolucency. And here Gruen zone 1, 2, 3, even 4. And sometimes in medially also we can see some radiolucent zones. So if they ask this kind of a question, you need to know how to touch this. Because you should start with detailed history, detailed examination. Another important thing, if they give us this kind of a thing, if you think about implant loosening, always you need to exclude infection. To exclude infection, you need to do the blood investigation. You start telling that I will do the full blood count, ESR, CRP. And this is the AP view. So you can ask additional view, lateral view. Then you can see how extended is the lateral view, also anterior and posterior. You can see any loosening zones. Then you tell the examiner, I will go through the operative notes. In operative notes, you need to know what are the types of implant they have used, what is the indication for the previous surgery, what is the approach, any problems during intraoperative, any problems post-operative. And we have to assess all clinic notes, very important, because that will give more marks. And next thing you can ask about further x-rays, especially immediate post-operative x-rays and sequential x-rays, whether to decide this radiolucent line is whether it's from the beginning or whether it's later developed, and what is assess the progression. If you can't with this radiologically, if you can't exclude infection, you can perform a WBC labeled bone scan. In addition to that, you can suggest I will perform a sterile joint space aspiration under X-ray guided, and I will screen it. And if there's a significant loosening, and especially you want to see the acetabular loosening and the bone stock around the bone, this much of radiolucent, you can organize a bone scan to see the bone stock. Like that, you can talk about the very generous and principles before operating. How do you screen this patient? And you need to mention, you will talk to the patient and explain the natural history of the implant loosening, and it could be end up with a catastrophic outcome such as implant fractures, bone fractures. You need to explain to the patient, and you need to assess the medical background and the patient activity status, his normal lifestyle. Then after that, it should be a multidisciplinary approach. That is a term wherever you need to use in your exam. And you can get your senior colleagues, revision surgeon's opinion. You have a wider breadth. You have already discussed in a wide range. Then you need to touch what are the possible challenges in this patient. First thing is you need to challenge is exclude infection. Then you need to assess the bone stock. And next thing is you need to get the previous surgery, all details, talk to the implant company and get the assistance ready for from the previous implant company. Because we don't know, we need to get all that particular removal instrument from that particular implant company. Talk to them, arrange everything. Be ready with intraoperative fracture is very possible because bones are very thin. Bone defects are more liable to give fractures. So be ready for intraoperative fracture management. Be ready with bone graft. Be ready with wide range of implant, prosthesis fixation, yeah, cables. Be ready with everything. Another important thing you need to mention, one, imagine now looking at, okay, you exclude the infection. Once you open, you get some pus, sometimes you get the pus, sometimes you get some suspicious fluid. Appearance are quite suspicious. Then if you are not happy to go with a single go, that's a single stage procedure, then you can go for a stage procedure, shift to a stage procedure, be ready with spaces. And be ready with all type of implants, and so correct positioning and do the, so if you touch all these areas, so examiner would be happy about in your exam how you, what is your approach. Then he want to go for operative stage, then he will go into that stage. If you go into that level in the implant loosening, that means you are already scored up to 7 or 8 level. Thank you very much.
Thank you, Ajith. That was a very exhaustive lecture, and I'm sure you've taken so much of effort. I really appreciate
Exactly, yes.
the effort that you take for.
Because I referred couple of papers and couple of textbooks and my notes, because my target is to give the maximum to the exam oriented lecture rather than descriptive. Yeah.
True, you cover entire spectrum of where loosening, the kinds of failure of implant and etc. It was fantastic to listen to you. There are some questions like, see, suppose while doing a total knee replacement, a small particle of cement lies inside the joint. So what kind of wear does it produce? Is it
No, it could be a third body wear.
Okay.
Then it could be abrasive wear. It starts with the third body wear, then it acts as, it made the friction and produce abrasive wear. So consequently, it's going to abrasive wear. You can tell it start with third body wear, and then it leads to abrasive wear as well.
And the other one is regarding that X-ray that you showed on cantilever bending.
Yeah.
And you mentioned specifically that the fixation is good in the distal part of the femur. So do you mean to say that the cantilever bending is common with distal fixing stems?
No, not really. But the mechanism is, it's a cantilever bending because of the proximally loosening and fixally distal is well fixed. It is toggle above. What happened over that? It happens associated with the fatigue failure. That's why I emphasize this cantilever bending, and the fatigue failure is very common, and it's a very common question they question in the exam. Because of the recycled stresses, cyclical loading, what happened? It failed at a low level of stress. But the reason is to distal secured, so it will bend at the mid of the shaft.
So you have shown basically is a cemented Exeter stem, is that?
Cement Exeter stem.
Okay. And what are the scenario? Why does it break? Why does it lead to cantilever bending? What is the reason for it?
Reason is the fatigue failure. That is fatigue failure. It is that once the cycle loading happen, that it's a mechanical the mechanical property that there's a yield strength that we have to discuss. When that is a yield strength, that is a maximum strength. Then it's go beyond that, there's a high chance of failure. But because of the recycle bend loading, cyclical loading, there is a possibility of failure at the low level below the yield strength. That is why this is failed. So we have to explain stress strain curve.
The reason why I'm asking is the cemented Exeter stem has one of the best survivorship rates, isn't it?
Yes.
So what is the scenario that a cemented Exeter stem leads to cantilever bending? I agree with what you say, it's fatigue failure. But is it like the end, say about 15 to 20 years after the implant, or anything that is abnormal regarding the I mean, if your orientation is lost or your position, why does it really break? That's a question.
Yeah, because I can remember we discussed that in detail. So because it's a exeter stem, it is tapering. It's a two-way tapering. So I will read it more about that.
Yeah, no worries, no worries. I know it's a very, I'm sure that
It's
question.
a tricky point. Yes,
Yeah,
yes,
yeah,
I
it's a
can
very
remember.
tricky
Yeah.
one. And I mean, you've mentioned about the different types of behavior like pistoning, cantilever. I mean, that was very enlightening, and I'm sure all these guys really understand the entire spectrum of where the mode 1, 2, 3, the Gruen zones and all that. So I think, Ajit, there are no more questions, and that's what I mean. It's a strong lecture, so it's going to get archived there in our channel, and it can be viewed by anyone anytime. So thank you once again, Ajit.
No problem.